Weak arm and hand. General features. It is unlikely in the context of PACEs, but is the patient cachectic or clubbed? Is there lymphadenopathy? Any of these features would suggest malignancy. Check carefully for breast masses and also for any abnormal chest signs, particularly at the lung apex where a Pancoast tumor might be found, indicated by wasting of the intrinsic hand muscles and Horner's syndrome. Are both radial pulses equally palpable, and is the BP the same in both arms? A positive Adson's test, decrease in the radial pulse when the patient turns the head to the affected side and breathes in deeply, may indicate subclavian artery compression, e.g. by a cervical rib, but the test may also be positive in normal subjects. Is there a characteristic skin rash of herpes zoster? Musculoskeletal. Observe how the woman moves her neck and shoulder, e.g. when removing her clothing before being examined. If movement of the neck is painful, then this will be held rigid. If the shoulder is painful, then the normal scapulohumeral rhythm of movement, whereby the arm moves in the shoulder joint before the scapula moves, will be reversed. Feel for local tenderness of muscles of the back of the scalp, neck, and shoulder, and also for tenderness of the shoulder joint itself. Neurological examination. Root and radicular lesion. Look for signs of nerve root lesions as shown in Table 17, the most common roots affected being C5 to C7. Look also for the following. An inverted brachioradialis jerk, which occurs when finger flexion is the only response to an attempt to elicit the normal biceps or supinator jerk. This may indicate a spinal cord lesion at C5-6, resulting in lower motor neuron signs at the level of the lesion, i.e. loss of C5-6 reflexes, and upper motor neuron signs below the lesion, i.e. brisk C7, triceps, and C8, finger flexion, reflexes, and pyramidal signs in the legs. If there is dissociated sensory loss, loss of pain and temperature with intact proprioception, in a cape-like distribution, i.e. suspended sensory level, and lower motor neuron weakness, it is likely that there is an intrinsic cord lesion such as a syrinx. Other signs may include Horner's syndrome, if the lesion extends to the T1 segment, and pyramidal weakness below the level of the lesion. NB. If the T1 nerve root is affected, Horner's syndrome may be present because of damage to the adjacent sympathetic plexus. Median nerve lesion. Look for evidence of the following. Signs and symptoms of carpal tunnel syndrome. If only the anterior interosseous branch of the median nerve is damaged, the patient will be unable to perform the ring sign, pinch grip, resulting in the thumb and index fingers assuming an extended position. Also, there is pronation weakness when the elbow is in a flexed position, the latter is due to weakness of pronator quadratus. The ring sign involves flexion of the distal phalanges of the thumb, flexor pollicis longus, and index finger, flexor digitorum profundus. There are no sensory changes, pure motor branch. In an elbow lesion, pronator teres syndrome, apart from weakness of thumb abduction, there is weakness of flexion of the distal phalanges of the thumb and the adjacent two fingers, anterior interosseous branch function. Sensory changes are as in carpal tunnel syndrome, plus there is decreased sensation over the thenar region extending up to the wrist. Ulnar nerve lesion. Look for evidence of the following. Most commonly damaged at the elbow. Wasting of first dorsal interosseous appears first, but later there may be involvement of the other dorsal interossei in hypothenar eminence. Difficulty abducting and adducting outstretched fingers. Froment's sign, distal thumb flexion, adductor pollicis weakness, when a patient is asked to pinch a sheet of paper between the thumb and second metacarpal. Sensory loss over the little finger and the medial half of the ring finger. If the deep palmar branch, purely motor, is compressed in Guyon's canal, which runs between the pisiform and hook of the hamate, there will be wasting and weakness of the interossei, especially the first dorsal and adductor pollicis. Hypothenar muscles are usually spared. Radial nerve lesion. Look for evidence of the following. Most commonly damaged at the spiral groove of the humerus. Major feature is weakness of wrist and finger extensors, wrist drop. Weakness of forearm flexion with forearm midway between pronation and supination, due to brachioradialis involvement. Sparing of triceps occurs if the lesion is at or distal to spiral groove. Sensory loss over dorsum of hand between the lateral two digits. If only the posterior interosseous branch of the radial nerve is involved, there is wrist extension, but with radial deviation because the extensor carpi radialis muscle is spared, brachioradialis and triceps normal, and there are no sensory changes, pure motor branch. Axillary nerve lesion. Look for evidence of the following. Wasting of deltoid. Weakness of shoulder flexion, abduction, and extension. Sensory loss over lateral deltoid. NB. Generalized axonal peripheral neuropathies will affect the legs before the arms and are generally symmetrical. Inflammatory or demyelinating neuropathies may damage individual nerve fibers and so could affect an arm first. NB. Myopathies that affect distal before proximal muscles are rare. However, one form of inflammatory muscle disorder should be considered, inclusion body myositis. In this there is typically disproportionate and marked weakness in the wrist and finger flexors relative to the corresponding extensors, so would cause difficulty carrying a briefcase, and disproportionate weakness of knee extensors compared with hip flexors. Further discussion. What are the neurological causes of pain in the arm? See Table 18. Neuralgic amyotrophy, brachial neuritis. This is characterized by acute onset of excruciating unilateral, although it may be bilateral, arm, usually shoulder, pain, followed by shoulder and parascapular muscle weakness several days later. The pain is so severe that it is often confused with the pain of a myocardial infarction. Presentation and nerve involvement can be variable. Sensory changes are minimal. There may be subsequent rapid wasting of arm muscles. Phrenic nerve involvement can result in significant breathlessness. Precipitating factors include recent trauma, severe exercise, surgery, infection, or vaccination. It may rarely be hereditary. The prognosis is good, with a spontaneous recovery rate of over 90%.